Good morning, and welcome to Westwood, California, and welcome to the Ronald Reagan UCLA Medical Center. My name is Isaac Yang, and I'm the lead neurosurgeon for the Superior Semicircular Canal Dehiscence program here at UCLA, the SSCD program. And as the lead neurosurgeon for this, I'll be talking to you today about SSCD, Superior Semicircular Canal Dehiscence. And this live webinar is being brought to you from Westwood here at UCLA, and I'm very happy to be bringing this to you over the internet. You can follow us along on Twitter at UCLA Health, and if you have any questions, you can Twitter them to us, or you can mark them with the hashtag at UCLA, hashtag UCLAMDChat. At UCLA Health tells us that this is the most registered webinar to date that we've had here, and so I thank you for your attention, and I'm very proud and honored to be part of the most registered webinar to date. And I think this particular topic came together, and this particular webinar came together just based on demand, actually. We had a lot of patients, former patients, and to-do patients who were just asking us to do an SSCD webinar, and so we are responding to that demand, and I think that's why this is the most registered webinar that we've had at UCLA, is because we're just responding to the demands. And my name is Isaac Yang, and I'm the lead neurosurgeon for this. My disclosure of independence: I have no financial support or relationship with any company related to this presentation. I do have research grant funding provided, and you can see those here as well as on my disclosures at UCLA. They're right here. So let's talk about superior semicircular canal dehiscence, and it's a mouthful. That's why we came up with everyone uses the abbreviation SSCD. And this is just SCD, semicircular canal dehiscence, is what's listed here. And superior semicircular canal dehiscence is a big mouthful, but it's really a simple concept and a simple disease that can have horrific impacts on your quality of life. And so this is semicircular canal dehiscence, and every person really has 3 semicircular canals on each side, on the left side and on the right side. And here you can see the superior canal, which is on the top side. You see the posterior canal on the back side, and the horizontal or the lateral canal, and that's on the furthest side out. And you have one of these on each side, one on the right side behind your right ear, and one on the left side behind your left ear. You also normally have 2 openings here into the structure, one right here and one right here, and this is very normal to have 2 openings. It's very normal to only have 2 openings. Now, superior semicircular canal dehiscence is the most common of the 3 canals to have a dehiscence. Even though it's the most common, this is actually quite a rare disease. This was first given a name in 1998. That wasn't very long ago. I mean, emails, internet, Facebook, all these things came around this time, 1998. That wasn't very long ago. That was only 15 years ago. Before that, this disease probably has been around, and it's been around for a long time. It just wasn't given a name. It wasn't given a diagnosis. And unless you know what something is, it's really hard to treat it. Well, in 1998, Dr. Miner and his team described this, and since that time, this entity now has a name of superior semicircular canal dehiscence. And so for the past 15 years, we now know what this disease is, what the impacts are, and now we're going to talk about the outcomes for surgical repair for this. And what this is instead of having 2 normal windows that you have where the sound comes in and the sound comes out, you have a 3rd window. See, in the superior canal, you develop a 3rd opening that communicates with the base of the skull. The brain and the ear, this balance nerve, ends up with an abnormal connection. This opening between the brain and this superior semicircular canal creates this disease called superior semicircular canal dehiscence, or SSCD. And this disease, this very, very small hole that shouldn't be there normally, that's not there in most people, but in the people that develop this 3rd hole, they have severe and devastating impact to their quality of life. And so this communication between the superior semicircular canal, SSCD, and the middle fossa, where the brain lies, the connection between the brain and this balance organ is what creates this sensitivity to sound and pressure, and it creates a whole host of auditory and vestibular symptoms. So your balance, your hearing, your vision, they can all be affected. And we're going to talk about some of the just really hugely impacting symptoms that this disease can have on your quality of life. So you'll see terms like this on the internet if you look up SSCD, and you'll see this in PubMed, you'll see this in the papers that me and my team that we write, but I just want to break it down. Oscillopsia. It sounds like a very complicated word, sounds like something out of the Wizard of Oz. It just means that your eyes are bouncing around. Your eyes move in relation to your balance organs. And because there's this opening, this third window, that's disrupted in a normal way, so your eyes start bouncing around. And you know what happens when your eyes start bouncing around? Your vision starts bouncing around. So your vision starts looking like you have a bouncing vision. You can also have pressure-induced vertigo, and you can have sound-induced vertigo. And there's a specific name for these symptoms. And basically what it means is, if I were to play a sound really, really loud in your ear, you're going to get dizzy. This is going to happen to every single human being. You play the sound loud enough, and you're going to get dizzy. And I'm getting older these days, so I can tell you louder sounds, the loud music I hear, it's too loud for me, and it just is. So any human being, if you play the sound loud enough, they're going to get dizzy. What happens in SSCD, because there's this third window and this abnormal connection, when you play normal sounds, just like us talking, the television, the door opening and closing, that sound by itself can induce or trigger balance or dizzy symptoms. And this is very, very detrimental to people's quality of life. Imagine if every single day someone's voice, anyone else talking, a door opening or closing, a knock on the door, a doorbell, your television, those sounds, imagine any of those sounds making you dizzy. It's a horrific impact to your quality of life. The other major symptom, one of the most common symptoms is autophony. Auto meaning yourself and phony meaning the ability to hear. You hear yourself. So autophony means a lot of people hear their own heartbeat. Boom, boom, boom. They hear it all the time from the moment that they wake up to the moment that they go to sleep. So not only are these sounds making people dizzy, but they hear their own heartbeat beating in their ears anytime they're awake. Imagine how irritating that must be. Imagine if you just hear this nonstop pounding, boom, 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 and it's nothing else except the sound of your own heart. Other people can hear their own eyes. Imagine every time you move your eyeballs, if you heard a squeak in your ear. That's the sound. You hear your own body. One of the complaints that we also see is that they hear their own footsteps. So each step that they take, they hear their heel hit the floor because that sound gets amplified through that third hole. And so these people don't want to hear sounds. If you have SSCD, you don't want to hear any sounds because every sound is so loud, it's going to cause you dizziness and painfulness. You don't want to hear your own heartbeat. You don't want to walk. You don't want to speak. This sounds like a horrible, horrific, hell-like condition. And this is what SSCD is like. And it was only given a name and diagnosis 15 years ago. And so people hear pulsal tinnitus. You can also get hearing decrease, and it feels like your ear is always full. And this is what people who have SSCD are dealing with every day. And this is a CT scan from one of our publications from Dr. Yu and Dr. Gopin, my collaborators, called Characteristics and Management of Superior Semicircular Canal Dehiscence. And here you can see this arrow. This arrow here is pointing right to the canal, the superior canal. And there should be white. On a CT scan, bone is white. And there should be a white covering to the canal here. There should be a white roof. And in this patient, you see the superior canal. This is that line. And the arrow is pointing to the top where there is no white line. There's an opening in this canal. There's an opening between this semicircular canal and the brain. So this patient heard their own heartbeat. She heard her own heartbeat beating, boom, boom, boom. She may have also had balance problems with just normal sounds. She may have had problems with her vision, problems with balance. She may have heard her own footsteps in every step. And so this was a severe problem. And so we've developed and we've instituted the SSCD program where we do a surgery to find this hole and to plug it. Now, does every single person need surgery? No. I'm a surgeon. I like what I do. I'm good at it. But I know that if you can avoid surgery, you should try to avoid surgery. And that's just fact of the matter. Surgery has to be the nuclear option. Surgery has to be your last option. You have to try everything else. Because surgery, what we're going to do is brain surgery. And I don't think anyone walks around and says, well, you know what, today I think I'm going to have brain surgery. No one says that. Nobody goes around and goes, well, I sure wish I could have brain surgery. And so this surgery is a really big deal. It's a big undertaking. Now, we do it really well, and we do it very safe. I'm going to talk about it later. And this surgery just takes about 2 hours. And so it's looking like a very minimally invasive, small approach. But nonetheless, there's no way to slice it or dice it but to say, you're having a neurosurgeon and an ENT surgeon do brain surgery on you. And so you just don't want to, if you don't have to have it, you don't want to have it. So the first thing is avoidance of triggers. If you can manage it with medications, some people's symptoms are so light that only really loud noises cause them problems. Well, if that's the situation, they're going to have to avoid really loud noises. But if you can't deal with the symptoms and your quality of life is quite poor, and you can't avoid the triggers, I mean, if the triggers are normal day noises, the television, opening and closing of doors, the sound of your own voice, or the sound of your own heart, how do you get away from your own heart? And so if the symptoms are severe and you can't avoid the triggers and nothing is helping, you should not have to suffer. We should try to fix this, and we should try to fix this with surgery. And so what we do with surgery is that we come down, this is the brain. You see these lobes of the brain. This is the brain up here, and what we do is we lift up the brain, we come down and find this hole in the superior canal, and we plug it. And here it looks like we're plugging it with a bone graft. We actually plug it with bone wax, a little bit of muscle, a little bit of glue, and a small piece of bone from doing the surgery. But the real thing is this disease has only been around for about, well, this disease has only been named for about 15 years. It's been around for a long time. It's probably been around for as long as humans have been around. But it's only been given a name for the past 15 years, and so that's a very short time. And so the real question is, how do people do when these diseases are fixed? And there's not a lot of literature out there. There's not a lot of data out there. And so we're really happy here at the UCLA SSCD program to give you our data. And I think that's where the demand comes from. I think that's why this is the most registered webinar, is that people want to know, well, how do people do? And so we can tell you how patients are doing. Now, one of the really cool high-tech things that we do here at UCLA is we do brain lab registration for our SSCD repairs. When we do this brain surgery, here you can see these cameras. You see these yellow cameras and these yellow screens. We reconstruct people's brains and CTs and skulls in 3 dimensions in the OR. And in real-time live monitoring, we can do mapping of the skull to find these holes. These holes are really small. When you look at canal dehiscence, you're looking at a hole the size of the tip of a ballpoint pen. It's a really small hole. But this really small hole, like we mentioned, causes huge problems. It causes problems to your daily life, to your balance, to your quality of life. You can't live, and it's all because of this itty-bitty small hole. Well, try finding a hole that size, the size of a ball tip pen, in the middle of your skull. And so what we use for every single one of our canal dehiscence repairs, every time we take a patient to do brain surgery, to do SSCD repair, we use brain lab navigation. And what this is essentially is pinpoint GPS missile-like targeting of the brain. We use this in all of our brain tumor patients, and we brought this technology over to skull-based surgery, to SSCD repair, and we use pinpoint laser-like stealth missile-locking GPS locking in using these high technologies so that when we find a hole and we plug it with the bone wax and the glue, the muscle, we know exactly which hole we're fixing. And we know that we're fixing this exact hole over the canal dehiscence. Because what you don't know, and what I know as a surgeon, because I've seen a whole bunch of these, is that there's actually a whole bunch of itty-bitty holes in the floor of the bone. And if you go to the wrong one and think that you fixed it, the patient's going to wake up and go, I don't feel any better. You fixed the wrong hole. And the thing is that there's multiple ones of these holes. And so what we do is we use this technology, this laser-like stealth stereotactic. I mean, it's like GPS, precision GPS, so that when we get to that hole, we use that as live real-time monitoring, so that when we fix this hole, we know that that's the canal, and that's the one that's going to be causing the problems. And so that's why our success rate, I think, is so high. And I mentioned this specifically because it's, I think, one of the keys to our success here. So we did a research study here and under the UCLA SSCD program. And I'm the lead neurosurgeon for this. The lead ENT surgeon is Dr. Quentin Gopin. And we looked at the patients that we've treated to find out their outcomes. What happens to them after we do this SSCD repair? And we used the brain lab navigation, which does laser-like focus for the canal dehiscence repair, in order to evaluate how our patients do after this repair. The other thing we do now is we do a minimally invasive. We do the smallest skin incision that we can with the smallest opening in the brain. And now our surgeries take about 2 hours. We recently did a live tweet of our SSCD repair, and that surgery took about 1 hour, 40 minutes or so. And so under the whole surgery, the whole brain surgery is about 2 hours, especially in uncomplicated cases. So it's a 2-hour procedure. It's still brain surgery, but we do it in about 2 hours. And we're not rushing. It's just that that's the way we do it in a minimally invasive, short, safe way. Because the longer you're under anesthesia, the longer your surgery time is, the more risky it is. And with the experience we have here at UCLA, with the technology, since we had the pinpoint marketing, we go straight down to the hole. We don't have to fuss around or guess about what hole we're fixing. We go straight down to the hole, and in 2 hours, we go down and fix this hole. So we looked at Dr. Gopin, we looked at my experience here, and we looked at all the canal dehiscences we've repaired here at the SSCD program here at UCLA. We looked at their clinical symptoms, we looked at their CT, we recorded their audio and vestibular symptoms, and we wanted to know, how do patients do? In this study, we looked at about 20 patients who got fixed with their SSCD repair, and all 20 patients received surgery. 9 males, 11 females, and the average age was about 56. And the age span is 37. So we've done SSCD repairs in patients as young as 37. We've also done in patients as old as 77. And that's the range of patients that we've done. And we have follow-up approaching 2 years of patients and how they're doing after SSCD repair. And this is just an example of the table and the data that we've collected, the age, their gender, what kind of surgery they received, middle fossa, symptom resolution, and their most current follow-up. 8 patients had repair on the left side, 10 patients had repair on their right side, and 2 patients actually had canal dehiscence on both sides. And both of those patients got both sides repaired between 4 and a year later, 13 months in between the 2 repairs. Our results are outstanding. 95% of our patients or more have experienced improvement or resolution of their primary complaint. We're very selective in the patients that we do surgery on. We want to make sure that you're going to get better with this surgery. And I think this is a testament to that. We find the patients that have the exact symptoms that you're supposed to have, that have the hole, and say, aha, you have the symptoms, you have the hole. If we fix the hole in 2 hours using stealth-like precision, your symptoms should get better. And we're finding that that's the case in most of these situations. We find that most of our patients, 95% of our plus of our patients, are happy they underwent the surgery. I mean, imagine if you heard your heartbeat every single day and that went away. You heard your own voice. You couldn't stand talking and that went away. You couldn't be around doors or TVs or other people talking and that went away. These people are immensely happy when these things get fixed. There's a small downside, though, is that after surgery, for the first 3 or 4 weeks, their balance can be worse. We found that in about 50% of our patients, and this is the balance organ, that about 3 or 4 weeks after the surgery, they have a transient, a short time where their balance just feels worse. And they're just getting readjusted because now they were so used to this third window, this canal dehiscence, their body and their brain and their balance organs have to readjust to this new balanced system that we've created for them by plugging this hole. What we did find is that that symptom goes away, and it goes away in all of our patients. So it's a temporary finding. It happens in a lot of our patients, but it's only temporary. Those patients are usually so happy that their other symptoms have gotten better They don't say much about this dizziness aspect. But I want this to be clear is that this is just the data that we've collected on our patients is that 95% plus of our patients get better. But a good fraction of them also have temporary 1 to 2 weeks of balance getting worse, but then that goes away. We have one patient that continues to experience some moderate symptoms even at last follow-up. And we'll talk about what we think contributes to those findings. In this study, what we did was we looked at different symptoms: autophony, hearing your own heartbeat, hearing loss, balance problems, sound-induced dizziness like we were talking about, like just a common sound of doors opening in and out. And we see headache here as one of the symptoms that we treated. And what's really interesting to note in our research study is that autophony, if you hear your own heartbeat, you hear your own voice, you hear the sound of your feet clicking on the floor as you walk, this SSCD repair is fantastic for making those sounds go away. It's also really good at improving hearing, and it's also really good because we had a patient with Meniere's disease who had no hearing. They lost their hearing, and they just had simply dizziness complaints, and those dizziness complaints got better after we repaired the SSCD. So those things, even with the short transient balance issue that some patients get after surgery, the vast majority, 95% plus of our patients get better from autophony, hearing their sound, and with balance issues, that most people get better with their hearing issues. Some people, though, they don't get quite the significant improvement. And what SSCD repair is not as good for are things with migraines and headaches. That some patients with SSCD have headaches and migraines, and we're finding that SSCD repair may not be the best improvement for those symptoms. But for the symptoms of hearing your own heartbeat, your voice, your own body sounds, SSCD repair seems to be a fantastic option. It's minimally invasive, it takes 2 hours, it's extremely precise. It is brain surgery, so we don't take it lightly, but it's a fantastic repair. There are some limitations to the study. It's a retrospective study. We were looking at patients after we had treated them. The reporting of symptoms were varied, and this is still a relatively small sample. This is actually the largest sample reported in the literature. We reported our results last year at the North American Skull-Base Society meeting in San Diego, so these results are public and we published them. These are actually even more updated results, is that we keep adding to this research study. So even though it's a small sample of about 20 patients, it's actually the largest reported series of SSCD repairs. And we hope that this establishes better techniques on how we can repair SSCD and still get fantastic outcomes. We find that most patients, the vast majority, more than 90%, more than 95% of patients have some clinical improvement and are happy they undergo the surgery. We find that history of headaches and we find that history of migraines may lead to a prolonged recovery. They may not do as well, and so that's something to evaluate very importantly. And we find that balance issues, that a temporary imbalance is associated with patients for just a week or two after surgery. This is the UCLA Journey. We treat every patient as individuals. It's not just SSCD. People don't just walk around with SSCD. People have SSCD. And so we treat people and patients who have SSCD. And we want to know, what are your individual findings? Because even though two people have SSCD, one person will hear their own heartbeat, the other person won't. It's like the other patients I've been talking about. Some people have balance issues, some people don't. And so every single person is different, and that makes sense. Except for twins that are identical twins, all of us are different. It wouldn't make sense that all of us are the same. And so we all have different symptoms, and so people with SSCD have different symptoms from their disease. It's almost like a fingerprint. And so we want to give people a fingerprint approach to clinical treatment. We want to treat every patient as an individual and with a personalized, unique treatment plan for them. We have a very close collaboration between myself and Dr. Gopin, the head and neck surgeon, who's the lead head and neck surgeon for the SSCD program. We have a close collaboration with pain specialists, audiologists, social workers, a whole team here at UCLA that go on this journey. And this SSCD program is a joint program between head, neck, ENT, and neurosurgery. This is multi-specialty care. It's not just me, it's not just neurosurgery, it's not just ENT, it's not just one doctor or one program treating you. This is a joint multidisciplinary team that comes together to give you personalized, life-altering medical care. Imagine how much your life changes if you can't stand to talk, you can't stand to be awake because you hear your own heartbeat, or you can't be exposed to normal sounds. You can't even stand to walk because you hear your own the walking of your feet. Imagine how life-changing that is if all of a sudden that goes away and you return to your normal life. And what we're doing is we're presenting the largest series reported and the biggest research study on SSCD, that this is world-class. This is cutting-edge research into things that no one else is really studying because we have tremendous volumes. We're also looking on trying to make this minimally invasive, making it the shortest operative time, the quickest, with the smallest blood loss, with the smallest incision, using GPS, using BrainLab GPS navigation to make it extremely precise. And that we wake up, everyone here at UCLA goes with you on this journey. When they have that slogan that it begins with you, they mean that. That's the slogan of our whole hospital, our whole health system. Every single doctor, nurse practitioner, resident, medical student believes in that mantra that it begins with you, the patient. That the patient has unique clinical symptoms, unique personality, and that they have this disease, SSCD, and that they'll have unique symptoms that we need to treat with state-of-the-art medicine, with minimally invasive, precise medicine that I would want to give to my family members, to my mom, my dad, my wife, my brother, my sister, that the same treatment that I would want to give to my family is the same treatment that we give here at UCLA. And I think that's why you should go on this journey. I'd like to acknowledge all the people that helped me do this. I obviously don't do this by myself. I want to thank all the people who are in the Yang Lab, including Lawrence and Nolan, who did a lot of this research work. I also want to thank everyone in the UCLA Brain Tumor Program in order for us to translate a lot of this brain tumor research using the BrainLab neuronavigation and taking it from brain tumors and using it to make our SSCD repair and SSCD surgery even more precise and more effective for our patients. And last but not least, I want to thank Quentin Gopin, who's the head otolaryngologist ENT surgeon for the UCLA SSCD program. He's one of the finest head and neck ENT surgeons here at UCLA, and he's absolutely fantastic. And I'd like to thank him because his collaboration with me and us putting this program together is really why our patients have done so well with SSCD repair. And I want to thank all the funding sources that allow us to do this research. This stuff doesn't just happen. It takes money to support the research, the time to do it, the computers, the research work, the program, the software, all the people in this room who are getting the webinars out there, and UCLA Health and UCLAMDChat, and all the programs. And a special shout out to Paul and Matt and Ashley and all the teams that are helping us get the awareness of this disease out there. And if you have any questions, you can contact me. This is the line to my office number. You can email me. You can also find us on Google+, Instagram, Facebook. We're at Isaac Yang UCLA Neurosurgery, as well as UCLA Health on Facebook. And you can find us on Twitter, either at Isaac Yang or at UCLA Health. And you can ask us questions with UCLAMDChat. We're always available, always around, and we love going on this journey. We love waking up every day trying to alleviate human suffering, and we love helping people with SSCD. And I really just want to thank you all for showing up and really making this a success. I want to thank everyone who registered and for making this the most well-attended webinar that we've done here at UCLA to date. Really just a tremendous honor and really proud of the program that we've built here. I just want to thank you for listening. I know this is not the most exciting topic, but I do think for people who are dealing with this disease, it has a tremendous impact on their life. And this is really life-altering information, because if we can fix this and we find that 95% of our patients are doing better, this is a treatment that we should be giving out to more patients so that anyone who has this disease has a really high chance of feeling better. All righty, thank you. I'll keep that last slide. And we're going to go over, I guess I have 5 more minutes, and I'm going to go over answering questions that have been given to us by Twitter or Instagram or Facebook, and we're going to discuss them, and then I'll try to answer them as best I can. So the first question is hearing loss a determining factor with SSCD, or could a person have hyperacusis hearing with SSCD? I have so many symptoms that no one can diagnose me. Absolutely. You can have hyperacusis, and that's what really we're talking about. Hyperacusis means that sounds are just excessively loud to you. That's where the word hyper comes from. And so you can have hyperacusis with SSCD. But really what it takes is we want to look at the overall picture. We want to look at all of your symptoms. And the way to get diagnosed with SSCD, because some people have these symptoms without SSCD, is to get a high-resolution temporal bone CT. If on the CT scan you don't have a hole in SSCD, or you don't have a hole in your superior semicircular canal, it doesn't matter how many of these symptoms you have, there's no hole there. And so you don't quite have this disease. And I wouldn't recommend surgery because I could do the surgery. I love surgery. I'm good at it. I want to do it. But if we did the surgery, we'd go down there. We'd find a bunch of different holes that aren't the canal dehiscence. And when we got to the canal dehiscence, there would be no hole there. There would be no hole for us to fix. And so the way to diagnose SSCD in particular is to get a high-resolution temporal bone CT scan. We have a question from Australia. They say, I'm from Australia, and they would like to know, they suffer from multiple sclerosis and would like to know if there are any case studies of patients with SSCD and MS who have had successful surgeries. I don't know of any particular patient right now who has had MS and SSCD or SSCD surgery. Diseases I have seen, are Meniere's disease. Meniere's disease is another disease where you have balance problems, you have hearing loss, and you have ringing in the ear. And so this patient had Meniere's disease and SSCD. So they had two really rare diseases. Either one of those diseases are very, very rare. And so this particular patient had both. And their symptoms actually got significantly better. And that patient is very, very happy with their repair after the SSCD repair. And so you can have multiple symptoms. And I think we as doctors always like to go to the simplest answer. We like to say, all your symptoms are usually due to one disease. And the vast majority of the time, 90, 95, the vast majority of the time, it's true. Most symptoms are caused by one disease. But it is rare and it is possible, it's not impossible, for you to have two diseases. For you to have this disease A and disease B. And so you could possibly have multiple sclerosis and SSCD, and SSCD repair would then fix your SSCD symptoms and not help your MS symptoms. But do I think that you could have both symptoms? I think it's rare. Both diseases are rare, and it'd be even more rare to have both in one person. But is it possible? Absolutely. This person says that they're 53, and their first sound-induced episode was when they were 15. And they heard the sound, and it threw them off balance, and it scrambled their sight, and they ended up passing out. They ended up having an audiology test that was unusual, but no one could tell them why. And they're asking if do patients have symptoms that worsen over time. So yes, that sounds like a classic history. One of our patients was convinced his SSCD started when he started shaving 3.5 years ago, or prior to him seeing me. He said that he started shaving about 3.5 years ago, and the clicker of the shaver, that's the moment in which he started having SSCD symptoms. And then he had them for 3 full years, and then right after the surgery, his symptoms got better. And he was so grateful, but he's convinced that that's what triggered it. And so, yeah, I think what happens, and we don't know exactly what causes this hole to form, but our theory is that some people are born with thinner bones than others. It's just like how some of us are born taller or shorter, darker or lighter, or heavier or thinner. Some people are just born with thinner bones over the SSC, over the superior semicircular canal. And so that bone is thinner in the particular patients who are just more prone to SSCD. And over time and over their life, that bone wears out and eventually punctures into a hole. And some trigger can be the moment when it punctures into a hole. And after that hole develops, you start having symptoms. And we've seen the age range. Our surgical range was as young as 37 and as old as 77. So that's how we think this disease happens. Now, the only way to be sure of that would be to find someone who has a thin bone and follow them over their life and watch the moment that happens. That's going to be hard to do. So in the interim, our best theory is that you develop a thinness and you are bound to have that symptom. These symptoms can get worse over time, but usually they trigger and they stay very, very bad continuously. And because you have one on each side, if you have one canal dehiscence on one side, we follow you very carefully for canal dehiscence on the other. And we see that a good 5 to 10% of our patients actually have canal dehiscence on both ears. And that goes along with the theory. If the bone is thin on one side, it makes sense that the bone will be thin on the other side. You do the repair on one side. For the vast majority of our patients, though, they only need repair on one side. That for some reason it broke on one side and the other side it's thin, but it's going to stay intact with no further follow-up. And so most of our repairs are only on one side. And we'll just wrap this up here. And I only have a few more minutes, and we'll do one more question. What are our thoughts on the RW approach as initial intervention? I don't know exactly what the question means in terms of RW approach, but there are different surgical approaches to canal dehiscence. There's the two most common, obvious, mainstream approaches, which is what we do, which is the middle fossa, the brain surgery, where we lift up the dura, find the hole, use a neuronavigation, and we fix it with outstanding success. The other one that's reported in the literature, one that I'm a little less enthusiastic about, is a transmastoid approach. They go, instead of from going, you can imagine if there's a hole, you could go from above, which is what we do, or you could go from below. And I think the way that, at least in the literature it's described, is that the coming to the hole from below has a slightly lower risk, a lower rate of success. And the reason why is because they can't be fully sure that that's the right hole. Furthermore, they can't be sure that they have a sufficient plug of this hole. And I think because of those reasons, that approach to it, at least in the literature, suggests that their rate of success is a little bit lower. We don't utilize that approach here because we believe that the middle fossa in this particular approach has a better rate of success. It does require a collaboration. If you just do a transmastoid approach, you won't really need a neurosurgeon involved. The ENT surgeon will do all of it and find the hole and plug it. If you do a middle fossa approach, you really do need a collaboration between a neurosurgeon and an ENT surgeon. I believe it works better that way as a teamwork, with each person doing what they do best and bringing it to the table. We believe that the middle fossa approach has a better visualization of the hole, that you can be more sure of which hole that you are fixing. I believe that it fixes and plugs the hole even better than coming at it from below. And I think this is our data which suggests that you have a 95% plus chance of success using a middle fossa approach, which is why that's the approach we use to fix this. Now, we do use the transmastoid approach for other canal dehiscences. We have used it for a lateral canal dehiscence, and we have used it for posterior canal dehiscence, and those are other diseases of the other canals. And so those approaches are really best approached through a transmastoid approach, posterior and horizontal canal. But for superior semicircular canal, it is our practice and our belief, and now our data, which we are putting out there, that suggests that the superior middle fossa approach is the highest rate of success with minimal morbidity, the best outcomes in a surgery that's about an hour and a half to 2 hours in a precise, minimally invasive way. And so we think, and I think, that that's one of the optimal ways to approach it. Now, do I think the other ways are wrong? No way. No. I think you can approach it in multiple ways, but this is the way that we approach it here because we believe that this is the safest, most precise, cutting edge way to approach middle fossa canal dehiscence repair. Thank you very much. I really appreciate your attention. Thank you so much for attending. Thank you for registering. Thank you for the great hashtags on at UCLA Health. Thank you for all the great hashtags at UCLAMDChat. Thank you for making this the most registered UCLA webinar to date. And please feel free to email us or contact us with any questions. And I look forward to seeing you again. Thank you.